Welcome to the final session of this meeting. Right at the beginning on Wednesday, we looked at the future of vascular surgery and the future of our specialty, and one of the clear messages was that our population is getting older, and we share that demographic partly with our orthopedic colleagues. So the invited Vascular Society's lecture this year is going to be given by an orthopedic surgeon, Scarlett McNally, who is an orthopedic surgeon in Eastbourne. She is Deputy Director of the Centre for Perioperative Care. She's a previous member of the Council of the Royal College of Surgeons, and she's had a bit of orthopedic surgery herself recently, but she's made it in person. And she's going to redefine the 6 Ps for us to tell us how we should manage our increasingly elderly population better in the perioperative phase. Scarlett, you're most welcome. Please come to the podium.
Thank you very much. Thank you. Hello, everybody. It's absolutely delightful to be here, and I realise this is the last session, so it's a bit of a whiz run through. Feel free to take pictures, ask me about anything, follow me on Twitter. I have no conflicts of interest. Just to say, the Centre for Perioperative Care pays me for one session of my time. I do lots of other things for fun on a voluntary basis. I was previously, for 10 years, on the Council of the Royal College of Surgeons of England, and there's a picture of me operating. It's a patient having a hip operation. I've done quite a lot on trying to increase diversity. If anyone thinks women can't do orthopedics, do come and see me, or whatever. So we're going to talk about perioperative care, patient-centeredness, prevention and prehabilitation. I understand Ps are very good in vascular surgery. So perioperative care is from the moment surgery is contemplated until full recovery. You can imagine there are lots of steps, but do be aware there are steps where one chooses not to operate, perhaps with the, after shared decision-making with the patient. So it's not an inevitable production line to get through. And the Centre for Pre-Operative Care is actually amazingly credible. There's a number of organisations are partners. It's largely funded by the Royal College of Anaesthetists to the tune of £1 million over 3 years. So it's basically, I feel like it's the anaesthetist buying me a coffee every day for my entire career. It's not all coming to me, obviously. There's a huge amount of work being done. And we produce new guidance. This is just in the last year. This is how to manage people with diabetes, frailty. There's a day surgery pack, how to reorganise services to be day surgery as the default option, and something on enhanced care, which is about between ward care and intensive care. So do go on our website, have a look at those. And just to comment that they are done with other organisations. We love working with others. It can be quite challenging getting the document together, but this is with the Academy of Medical Royal Colleges, getting it right first time, British Association of Day Surgery, all those other things. So do look for those. And basically, we do what we've always done, so it's trying to get people to change the practices. If someone's got dementia, they're far better off being a day case, for example. I realise that doesn't apply to most of vascular surgery. And basically, we know that things go wrong, and we know that there's huge unwarranted variation across all 4 nations of the UK and indeed the world. And some of that could be improved with change of practice rather than better perfection of the operation. This is just some numbers. So 10 million procedures in the UK every year. 14% of patients express regret. 10 to 15% of operations have a complication, obviously depending on how it's defined. 5 times higher if someone's frail, 4 times higher if someone's physically inactive. But this is a modifiable risk factors. So the World Health Organization did a very good report in January about if you stop smoking just for 4 weeks, you can reduce complications by 50%. They reduce by about 19% a week. So it's really worth doing. Daily exercise has got a number of papers, and the best results are with cancer surgery, where people have a very small amount of time to prepare. Lots of operations are cancelled, as you know, due to lack of beds or lack of intensive care beds. There's a variation around the day surgery and who's admitted or not. And the population we're operating on, 50% of patients operated on that require an anaesthetic are over the age of 65, at which age 50% of the population are multimorbid, which increases rapidly with age and multiple comorbidities, and 27% of the UK population do no exercise at all. The reference for that are in a paper I wrote on sustainability, because basically if we do fewer operations, that's the most sustainable thing of all. It's reduce, reuse, recycle, or fewer complications, fewer use of things. So CPOC, do you follow us? Just please feel free to look on your phone throughout this, take pictures, whatever you like. Look at cpoc.org.uk, save it to look at on the train on the way home. We've done evidence reviews, so we commissioned these to show the reduction in complications, the reduction in bed length of stay, and this is with better team working, trying to share skills so that people ask questions early on, so you're not discovering things a little bit late, and so that others in the team are kind of empowered to start some questioning that might lead to a different form of treatment or preparation. And it's proven better patient satisfaction. So we've got some lovely things for patients. It's the teachable moment. We want them to change their life to get better for the rest of their lives, not just for this marathon they're about to undergo. So I'd like to introduce you to my mother, aged 86 with dementia. And she had a fracture in May, just for the non-orthopedic, well, you're all non-orthopedic surgeons. You can see on the left, the ice cream has fallen off the ice cream cone. So if that was a hip, you'd do a replacement for that. But it's the shoulder. So should she be operated on, either reduce the fracture or replace, or leave it? And I thought it was going to go on to a non-union. She's got a few other factors. But anyway, it's joined, rather surprisingly. So there's the risks of horrible pain, pressure sores, not being able to get up and walk. We had to get one of those ejector chairs, all sorts of things. Or there's the benefits. So one has to just have that conversation with each patient. With each patient, it might be different. And there we are out going for a walk. She likes going for walks, so that's lovely. And it's about empowering patients. And the problem is, perhaps we've been a bit paternalistic, telling people what they want. We need to listen. We need the patients to tell us what they want. What is it that they're living for? What do they want to achieve? And we need them on board with doing the getting ready, doing the preparation. And we need to do shared decision making. I mean, for that, we also need information for the patient and for their family. So please, again, look at the CPOC website. We've got lots of resources about shared decision making. So it's not that being the patient's advocate, the customer always right type of thing. It's about the patient coming with their values. Interestingly, the little video there with Lawrence, the patient representative, is actually about abdominal aortic aneurysm surgery. So do please look at that, because that's very new and quite challenging. And shared decision making, what we want the patient to come with us is BRAN, the benefits, risks, alternatives, and what happens if I do nothing. And actually the natural history of a disease isn't always known. So we need them to ask the questions so we can answer them. But the shared decision making should be with the person who's got the answers. We also need to push the patient to prepare well and set the patient expectations in that as part of shared decision making, because it's about the fixed risks but the modifiable risks. Any of you know that there was a nice guideline on shared decision making? Great. Well, that's what it says, so I've just told you that. There's going to be some new guidance on how to record it from the patient record standards body quite soon. And what NICE has suggested is that you have an option talk where you talk through with the information. You have a team talk with the patient, with anyone that else they need about what this might involve, and then a decision talk about what's actually going to happen. What I've been recommending, I mean, I'm sure you have MDTs and you have a number of consultations with patients, but in orthopedics, we're very much pushed to a one-stop shop model to make a decision because they've seen the physio for a year and they've been, fobbed off for a year, they feel. But actually, bringing people back for a second consultation is very useful to help give people time to think, and that's the way the admin system actually allows that to happen. And actually, surgeons think they do shared decision making, but if you look at it, and there's a couple of references there, they really don't. So I urge you to either look at our website or sign up for some training, and Magic is quite a good training course that they do at Guy's. choosing wisely just because we can doesn't mean we should is, again, a nice paper you could look for if you want that reference. So moving on to prevention. There's really lots of sorts of prevention. I'm going to talk about 3. Primary prevention, which means never getting something, or reducing your risk. So if you do exercise for 150 minutes a week, you reduce your risk of ever getting dementia by 30%. So you never know you would have got it, nobody notices it, you just don't have it. That's a primary reduction in risk. Secondary prevention is catching it early, if there's an easier form of treatment for doing so. And tertiary prevention is really treatment, and we should be doing this and pushing this all the time to reduce complications for when people have the condition. And there are actually 7 things proven that to reduce complications before surgery. Smoking, I've mentioned. Exercise doesn't just work by improving heart and lung fitness and oxygenation. It has an effect on inflammation, and it has a metabolic effect that's quite powerful, and it's very empowering for the patient, and it has an effect on pain management. So exercise is your biggest winner here. Nutrition is very important, particularly vitamins and vitamin C, for example, fruit and vegetables. And then the medication review and senior review for patients who have multimorbidities or are complex is important. And for some, it will make them day caseable, which is good for the service and the patient. So I just stole this from a screen grab that Stella Vig was talking on peripheral arterial disease recently, so I stole that. She said it's important to diagnose it because it's the same risk factors essentially, and it reduces the, 20% chance of getting a stroke or an MI within the next 5 years if you've got vascular disease diagnosed. It's the same risk factors, isn't it? And the World Health Organization has written about non-communicable diseases, how can we improve health? And it's basically exercise and nutrition. And these are the 5 things that they say can happen. So basically it's lots of cycle lanes, please. Encourage active travel and healthy commuting, all that kind of thing. And changing behaviour is actually quite difficult. You sort of need to fit it in your schedule. Everybody knows they're going to go to the gym, but they never quite fit it in, or they think they do things and they don't quite. So it needs to be, you need to have a trigger to get going, and practical things. So I have waterproof trousers in my bag if I'm cycling to work in case it rains on the way home, for example. But we need to, it's not just the individual, it's about changing the environments, for particularly for people that have less opportunities to change. See it as normal, change the culture, change what's expected, change the infrastructure, and put the regulation in. And so what are the options for people? A static bike, very handy. Swimming is great, particularly for orthopedic patients that aren't wanting to do impact loading, for example. Fruit and vegetables I mentioned, for prevention. And just to note that low carbohydrate diets are beginning to have more evidence of efficacy in reversing type 2 diabetes. In Australia, they produce some new guidance as well, which, and that should be considered. It's not necessarily the really low carbohydrate ones, which are the keto ones, but just a low carbohydrate diet. And that because there's less of a spike of insulin, there's less of conversion of the carbohydrate immediately to sugar and immediately to fat. So, and people then don't feel hungry a few hours later. So that's the plan. And if it can't be low carb, it should be low GI, low glycemic index foods. So this is challenging to the official guidance from what was Public Health England about having 40% of your intake being from carbohydrates. So I'm just highlighting that as a challenge. This was from a report I was lead author for the Academy of Medical Royal College on exercise, the miracle cure, and the role of the doctor in promoting it. And this was basically, it can reduce your risk of bowel cancer and all that stuff. That's the primary prevention column, all those percentages. And in the right-hand column, does it do the tertiary prevention? Yes, it does, for absolutely all of them, apart from when you've just had an operation, where you're advised not to do what your surgeon has told you. And the biggest benefit is those who do the least. It's just getting up off your sofa is the biggest benefit. I've put a little triangle there at the 150 minutes a week of moderate cycling, which is kind of what every adult should do every week. Moderate activity, very brisk walking, swimming, that kind of thing. I've put the little arrow there because it's measured in Met hours per week. And so the biggest and this is from a different, I borrowed this from a BMJ paper. It has different effects on different diseases, but the effect is there for all of them. And to remind you, 25% of, this is English adults, do no exercise per week. And you can learn how to do motivational interviewing, particularly around exercise, on movingmedicine.ac.uk. So again, please write it down and look at it. There's some amazing resources. I'm going to go through it shortly. And for the rest of your teams, get them to go on e-learning for health, e-lfh.org.uk, making every contact count. You can do the training, and it's lovely training, and it teaches you how to get people to stop smoking by listening to what's making them smoke. You have to listen, and you ask them, you assess, you give advice and make some action. It's not about nagging. But as surgeons, we're allowed to nag because people are used to being told what to do by surgeons. So we are allowed to be a little bit stronger. But for the teams, making every contact count is fantastic. And actually, why do we ever do anything? This is the Orthopedic Guide to Brain Chemistry. I've borrowed it. There are some things that make you procrastinate when you ought to be doing it. And actually what we need is little goals. What you need is mini rewards. And you need to be included. So you're far more likely to do something. If you've signed up for a charity and you're doing it for someone else, you're more likely to stick to your training schedule. And we need to do things together. And just a note, the endorphins take 20 minutes to work. So I tell people to have their running shoes by the front door. So when I see these people that have fifth metacarpal fractures and they've punched someone, which is great, they didn't punch their partner, but actually you don't have to live like this. You can have your running shoes by the front door. No one has to get angry. There's no time. You can't just walk out and go, I need time. And just walk out and slam the door. That's fine. It's all good. But don't punch yourself, because that's your livelihood. So, but the endorphins take a while to work. You've got to just get out there before they kick in. So this is the Eastbourne. They had 3 people diagnosed with cancer in the space of months, so everybody got together and did an amazing walk. Park run is amazing. The Royal College of General Practitioners signed up to practices to be park run practices every Saturday morning, 9 o'clock, around the country, around the world. That's great. So everybody did their training for that, and they were together. It's such a best team bonding I've ever seen. I was the one taking the pictures. So choose your thing. We've done some stuff about swimming. We've done some health guides for people with conditions who want to go swimming, basically saying it's much safer to do something than to do nothing, and to encourage pools to be more friendly. So done that with Swim England. And the best forms of exercise, those fit into your everyday life. So I'm trying to get the British Medical Association to republish the Healthy Transport, Healthy Lives, particularly with the new information on pollution and on climate change that's coming out more recently. Electric cycles are a complete game changer. Those are 2 of mine. I've now got 3. And basically, if you're you always want to go out, because even that big hill, you just push the button 3 times rather than twice if you're just not quite feeling it, if you're feeling a bit lazy. So you always get, and you actually get just as much benefit because you go out for longer and more often. And the benefits of active travel outweigh the risks 10 to 1. Benefits to health outweigh pollution and collisions 10 to 1. There's references there. Now on to prehabilitation. And prehabilitation is generally coached exercise with something else. And various people have set up services around the country for that, with something else like talking, coached, talking about smoking and so forth. And to mention the Chief Medical Officer's guidance for all adults. So it includes frail people, it includes very old people. And I've put up their infographic for disabled people because it includes people with disabilities. And everyone should get 150 minutes a week of moderate exercise, but also twice a week of strength, twice a week of balance if you're a little bit older. And for frail older adults, some of that's up and down the stairs, go out for a walk, break up, do sit to stand exercise, that kind of thing. And the prehabilitation, the problem as surgeons, I think we're too polite. We think someone else will do it better. And sure, they'll do it better, but actually there's a workforce crisis in the NHS and they're not there, and people don't listen to them nearly as much as they listen to us. So we need to just tell people where to start and encourage the teams and mention it. Some more resources from Moving Medicine. We've just done one on, I just helped a bit, on perioperative care. So if you go to there, look at conditions, and one of them is perioperative care. And it tells you how to do it in a 1-minute consultation. New stuff that came out from the Faculty of Sports and Exercise Medicine, it's safer for people to be active if they've got long-term conditions than not. And look for that active hospitals programs. This is something some of your the physios, the occupational therapists, the nurses can do. It's kind of exercises you can do in the bed or around the bed to make it an active environment. And lots of other things that you can do in the community with GPs that people can send people to. They've kind of all mushroomed over different parts of the country. We've got to work with the whole team. It can't, not just relying on us. We've got to give permission almost to the whole team to do things. And there should be transdisciplinary working. So it's, I'll explain that in the next slide. It's about identifying what things you want to be disturbed about almost, but allowing them to do some of the other standardized pathway. And it's better for everyone because there's less moral injury if you know that you're doing the right thing. And this is where the transdisciplinary comes from the Academy of Medical Royal College's report on the multi-professional team. Because the problem with MDTs is everyone's so busy going, oh, well, the physio could do it so much better, but it's a pity she's not here today. What you need to do is go, well, the physio would tell you that you've got to do sit-to-stand exercise and would tell you you've got to sit with your knees apart and not cross your legs. You've got to kind of pick up the simple skills of the people that aren't there. And then meet as a team, use the data together, get the team to really feel like a team. In the old days, we'd have going out for whatever things, but now I think we should bring the whole team into an audit meeting and talk about not just the surgical, talk about everything, how we get the team better. How come we're always late on a Tuesday? What do we need to do on a Tuesday? Kind of just listening to ideas to change it, get the receptionists involved, get them to hand out the patient information leaflets, because anything that's on the patient information leaflet is fair game for the receptionist, the healthcare assistants to talk about. So this is a hip fracture unit from East Sussex, and it tells you how to use crutches if someone gets admitted over the weekend. It tells you if you're going in a chair, going home in a car, put a plastic bag on the seat because you can swivel around. That's easier. Otherwise, you're waiting for hospital transport. You might catch someone's relative to take them home at the weekend, for example. Just a plug, we've got a role called Doctor's Assistants that I led in developing in East Sussex. These are amazing people. We developed them from healthcare assistants, so it's level 3, so it's about £20,000 salary, a 2-week induction, and then we've got an apprenticeship, which is mostly online, and we've won awards for that. They can't do medication, but they basically run around getting the patient information leaflets. They can give information give out information leaflets to patients. They can take blood. They can chase results. They can make phone calls to get the patient list up to date. Draft a discharge letter that the doctor has to check. Nothing to do with drugs. It's all it's magic, absolute magic. And there's a paper in the BMJ Leader about that. So basically, perioperative care is better for patients, better for costs, better for staff. So you all know that, and everybody just needs to do it. For some people, money is important. So this graph shows the 3 little dots represent people, and how much, and the area of the curve is how much everything costs. So 3% of patients cost 45% of hospital costs, and it's the 3% of patients with multiple complications, should we say, or problems that stay in for a long time. I wrote a BMJ article that I thought would change the world in 2017 with Mia Gray and some others about if we concentrate on physical activity, if people can actually get up out of their chair and walk to the lavatory, they don't need to have a live-in carer or to go into a care home, perhaps. So it reduces the costs of care massively. And I thought that would change the world, but it hasn't. It's on my own website. There's a paywall, I'm sorry, with the BMJ one. We've written the pre-operative assessment and optimization Centre for Perioperative Care, and look at those logos, isn't it great? We work with all of those people, so it must be right, mustn't it? And I wrote an editorial on that, and I'm mentioning this because this is the graphic that was in the editorial, but we didn't manage to get in the actual guidance. It's basically you get your nurses and everybody to, you can algorithmize it and everything. Is someone low risk, in which case they need positive exercise, nutrition, be positive, all that stuff? Or are they high risk, in which case they need the shared decision making, they need the anaesthetist, the geriatrician, that kind of thing. And this is just a little tip about assessment and optimization. We're surgeons, we're not just doing a test for the sake of doing a test, we're doing it so we can do something, intervene. So get people to, how many sit-to-stands, I won't do it with you now, how many sit-to-stands can you do in 1 minute? Get your patients, can they do 40, can they do 20? You can test them, You say, I'm going to test you next time. They love it. They love it because that's what the doctors told them to do. And can you, get them to do 40? How far can you walk in 6 minutes? Everyone's got, watch, 6 minutes. Blah, blah. And get them to do 400 metre. Can they do that? And go for a walk every day. Just absolutely clear what you're asking for. But this is cheating because you're using the assessment to optimise. Just little thing. So I've borrowed some slides from 3 awesome people. So I'm going to flash through them now. So this is the prepwell.co.uk group that's doing a prehabilitation programme in South Tees. And they're fantastic. They've got some lovely results showing that you give people, this is a personalised programme, costs 400 quid per patient, but basically it reduces people's depression, it improves them getting enough exercise, that kind of thing. We haven't got results on this about reducing complications, but it seems to work, apart from smoking. This is Bart's Health, and this is quite clever because they've got a little app, but they pay a physio just 1 session a week to go through 100 patients to give little motivating personal things to patients. So you get your business case together, and you can do this kind of thing. And they've written that up, and that's Will Ricketts in Bart's. That was particularly for lung cancer patients. This is the perioperative medicine for the older people undergoing surgery, the POPs team at St Thomas's. So these are from Professor Jagdeep Desai, who's in St Thomas's. And basically, the emergency thing is on the right, and the elective thing is on the left. And basically, again, the screening, does the person need assessment? So they've found that 14% of people decided against surgery when they have a complex geriatric assessment. They've trained up some nurse practitioners to do some of the assessing and interventions. Lots of having medicine change. So they're working with, the geriatricians are working with the surgeons, but also having discussions about, does someone need the operation? Is that what they're expecting, the result they're expecting? And to mention that actually more of their patients are emergency patients than elective. You don't need to just, it's never too late. Even if someone comes in as an emergency and they're going to have a hip operation, you get them doing their arm thing so that they can use their aids afterwards. So what can you do? You can every one of you can start right now, movingmedicine.ac.uk, and start, just mention it and smile and talk and bring your, get the team involved. You can lobby for funding, get the business case, all that kind of stuff. And this is also me. So actually, I was exactly 3 years ago, I was catastrophically ill with myeloma and cardiac amyloidosis. This is me looking a bit cyanosed. I couldn't walk up a flight of stairs. It's why I got so good on Twitter. 2 stairs, bit of a tweet, 2 stairs, check someone, 2 stairs. Obviously I had a bit of chemotherapy and got a electric bike. Fantastic, because you can build up your exercise quite at your pace. I was told I was too unfit for a stem cell transplant. So I had a stem cell transplant exactly a year ago, and that's worked amazingly well because I demanded an echo. It's doctors as patients, hey. I demanded an echo and all that stuff, and I was in a Bruce protocol, and I knew what I had to do, and I got it because that's potentially curative. And I've been doing great, been back at work part-time, as you can see, hooray. And my hip had I needed a new hip replacement, which has done amazingly well, as you can see. So we're now 7 weeks. But again, I was cycling 70 miles a week with my arthritic, horrible hip that I couldn't walk, but I could cycle. I was cycling up to Beachy Head and back every day, or 5 times a week. And now I've got myself a static bike because I'm not allowed out because I'm a bit wobbly. I got that at 3 weeks because I was so frustrated because I lost all the endorphins. So I've got that. So that's sitting in my room, and you just sit on it for 20, 30 minutes and you feel, you're getting your thing. And I know you're all looking at that and going, who wears a wig when they go for an operation? But it's great. I've now acknowledged that hair grows at 10 centimetres a year, and I've now acknowledged my chemo curls. So this is the new me, because actually we keep reinventing ourselves. No one's perfect every day. I usually end on this, you've got to give space to people who are wobbling about on their bikes, because that might be the one time they're out. So just do it. And it's coming into the law next month, I believe, in the new highway code, 1.5 metres. Just saying, if you can't overtake, just hang back. They're saving you a space, carving space anyway. But I wanted to end on this, actually, about prevention, because prevention is primary prevention, secondary prevention, tertiary prevention. And the secondary prevention, I do understand that you do screening for abdominal aortic aneurysms, and I just wondered if someone could help me. And you know where I am, scarlet.man, nhs.net, whatever. how are we getting the shared decision making in? How are we getting those people going, no, do you know what? I don't mind if it all explodes. I just want to get to my, I couldn't take the risk, or I just want to get to my grandson's birthday. At what stage are we getting that in early enough? And if you're catching this high-risk patient population, at what stage are we getting the prevention in for everything else? Who's doing it? It's not just measure, and I'm just asking, if it's all in place, that's great. If not, do talk, please. So that's it. We've talked about all the new P's of vascular surgery, perioperative care, patient-centeredness, prevention, and prehabilitation. And to remind you, there are 7 things you can do to improve health, and do follow up. Actually sign up for newsletters from CPOC, because it's great, and it just reminds you once a month, and it's great. And we've got, as I say, paid people that do the publicity and write out the newsletters. You just contact at CPOC_news or cpoc@rca.org.uk. Just go, please send me a newsletter, Alice, and she'll go, yep, and it's great. Or follow me on Twitter at Scarlett McNally, but you'll get an awful lot about why we haven't got cycle lanes in Eastbourne, and it's very frustrating. And that is enough. Thank you very much.
Scarlett, a tremendous and inspirational talk. We've got time constraints this morning, so we can't have any questions, but you have given us your email address, and if people want to contact you, I'm sure you'll be happy. Also, this lecture was filmed, so all that information will be on the website with all the links that you've said. I would just want to shake your hand. Many thanks for coming.
Thank you so much.
You made a great effort. Thank you very much indeed.
Thank you. It's been lovely. Thank you.